that kind of in the back of your head. And the next big thing will be the midterm. Okay, so we're going to kind of talk through the lecture today. For the earlier sections, I came in like 45 minutes early and wrote out some notes. Don't feel deprived. So you'll get the same information. All of the notes, so the pictures from our class workday for all three sections, that way you have the benefit of all of them. The notes for this lecture and our last one, so a completed note list. The handouts, the videos, all of that stuff, the cartoons and figures that have been in the slides that we have used, all of that will be on Moodle this evening. And so the reason for the delay is that way I can take out stuff that we haven't covered. Does that make sense? Because remember, if we don't cover it in lecture, it's not on the exam, right? And so hopefully that is we can't have come to the same logical conclusion, right? Okay. So I promised last class we talked about the APGAR scale, and I promised today that we would talk about anesthesia. We're going to mention analgesics, but not really. We're not going to say much about it. We'll talk mostly about anesthesia. Then we'll talk about preterm births. We'll talk about birth weight. Everything from just a generally preterm birth to a preterm birth that is around between the 22nd, 25th week of life, and then we'll talk a little bit about stillbirth, and we have 2 short videos to watch, and that should send us careening into our weekend and the new month. Okay. So let's start with anesthesia, and I can put the numbers up that way you have them to write down. Now, if you can choose, since they're all going to be on Moodle, you can choose not to write them down if you want. The reason why we do both, or I like to do both, is that especially for individuals that are just starting their college career, you may not know exactly what your learning style is, and so I found that writing it down and then reviewing it and hearing it spoken, the triangulation of those 3 can often help with exams. So it's just there to help you, but if you already have a sense of your learning style, do what works for you. Fair enough? So what you'll see in your textbook is you'll see that 80% of all births, anesthesia is used, some form of anesthesia or analgesic, so some pain reduction medication. Now that doesn't mean that every mother is choosing to do that. So for example, if someone goes into labor and their baby is breech and there isn't a way to correct for it, they may have initially chosen the Bradley method. Remember we said the Bradley method was, I want it natural as possible, no medications of any kind, all of these things. But there may be a point where we have to do an emergency C-section and they'll have no choice, right? Because there's no Bradley method for C-section. If you're going to into something, right? So we'll say 80% uses anesthetic, or of the mothers that are anesthetized, or have some kind of pain reduction medication. Now 1/3 of that are the epidurals. An epidural, as you know, is a spinal block, so the patient will be numb from the waist down. Of course, epidurals, having an epidural done is not limited to labor and delivery, right? We all know that. Now, this creates some significant problems for our mother. So if you're numb from the waist down, you're not getting up to walk around, and you really can't help push. So we can see that there are some immediate problems with that. So the way that we've gotten around that is through a walking epidural, and it's also called a dual spinal epidural. And so the difference is, there are a lot of differences, but the basic difference is that you have smaller needles, more controlled injection. So a block with a traditional epidural lasts significantly longer than whatever procedure you're having done. Now you might say, why would that matter? Why, you might think, well, if I'm giving birth, I'm not going to want to walk around, and that would make sense, but it's not necessarily true, because for some women, starting active labor in a tripod position on their bed, so you jack the bed way up and let them tripod over it, is much more comfortable. For some women, using a birthing ball is more comfortable. And so it eliminates all other options. Does that make sense? So the walking epidural. And it's called this because mother can walk, can get up, do stuff, can help push, and the half-life is not nearly what it is for the traditional epidural. Any questions about that? Now, in general, you'll notice the textbook talks about kind of this, that there is some evidence to suggest that anesthesia can affect the fetus, and there's some evidence that says it's not so bad. And what you should gather from that is it's not a case of two equal opinions that you get to choose between. It simply means it's an active area of research. And there's some things that we don't know. What we do know is that it can depress oxygen. That should make sense on its face, right? If it's doing it to mom, it's going to do it to the fetus. Doesn't matter. And so that could be a problem, especially if you're already in something of a hypoxic event, which birth is, right? So if you're doing that and you're combining it with some medication that can reduce respiration, there's potential for a problem. One other thing, you could have longer effects. So you'll notice in your textbook that it will say the fetus may have a reduced motor control. Now, what's happening in your textbook that I think is important to keep clear, we know, because we've discussed it, that as soon as the fetus emerges from the birth canal, it's now a neonate. It's no longer a fetus, right? And so your textbook is still using the term fetus, but it's talking about a neonate, like right after birth, because there is no way that I know of, and I have a lot of friends that do motor research, to assess motor function in utero. Like, you can't hand a fetus a novel object and be like, grasp this, right? That would be inappropriate at best. And so we're talking about just after. Also, up to a year, so that up within that first year is when an infant will start to sit and stand and maybe take first steps, but that's usually a year to 18 months. And that can be delayed. Now, it's important to recognize that there's a natural continuum when this stuff happens. And so my opinion is that I don't find it very valuable, because in the absence, you can take a sample of natural births and see that there's a lot of variation from those infants and when they start to sit, when they stand, all these other things. And there's some evidence that it can affect the mother-infant time. Now, part of that is because if you're lethargic because of medication and the baby's lethargic because of medication, then certainly you're not going to be holding, you're not going to hold your baby or you're not going to have a patient hold a baby if they can't do that safely. You'll see in the textbook that we said before that the jury's really out insofar as skin-to-skin contact is concerned for bonding. We don't imprint. But it is important for motor development, muscle development, all of these other things. Doesn't seem to have anything to do with bonding, but there is some positive effect. And so you can think about things like infant massages, and generally it's recommended that you massage baby 3 times a day, like these light massages. And so that certainly can be affected if the mother's not at 100%. All that make sense?
What was it called when it's a skin-to-skin contact? Like, there was some kind of name for it, like what they referred to it as, wasn't there? Textbook.
I believe you're right. I don't
I
recall
don't
what.
remember what it is.
You won't have to worry about that because we'll talk about it as skin-to-skin contact. And if I ask you about it and I'm using something other than skin-to-skin contact, I might say, you know, what principle did Lorenz come up with for mother-infant bonding, and you would know that skin-to-skin contact is the answer. Right. Anybody want to search for it? Luckily, we don't have to guess or wonder. We'll wait awkwardly while it's happening. Huh?
I said I don't have a textbook on me.
It's okay. Yeah, it's no problem. We're all friends here. Okay. While we're waiting on that answer, let's talk really quickly about post-delivery stay at the hospital. Nothing more to say that insurance companies have come in and have done horrible things, and all they care about is money. And so, I don't know that that's entirely true, but that's the way it seems, because you saw in your textbook that from the 1970s to today, we went from an average of 3.9 days postpartum in the hospital to often 24 hours. That was up until legislation was passed that said that insurance had to cover for at least 48. Yeah, and it depends, obviously, on where you are as well. So I've heard, my wife and I, and my wife especially, were originally from the East Coast. My wife's from Manhattan, and her sister, like, they're wham bam, okay, you've delivered, now go home. Unless something crazy's going on. Here at Stanford, at least, they're South Dakotans. Like, stay for a while. Have you seen our bistro? Like, no, I haven't, matter of fact. Let's go check it out. And so it depends on the culture and the hospital, how many people they're serving, how many beds they have, staff, all of these wonderful things. So let's move quickly on to preterm infants. And let me write some of this down, that way we're kind of on the same sheet. Maybe I'll use this board because I'm lazy and that's more. Okay, so we're going to talk about a couple different things. We're going to talk about this overarching category of preterm infant, and we're going to talk about low birth weight within that category, and then we're going to talk about little for gestational age, and we're going to be talking about very low birth weight infants, and they all kind of fit together, and you'll see how the divisions are. So, preterm infant, very simply, is an infant that's born, however it's born, at least 38 weeks or under from the point of conception. Now, of course, we know that conception is an estimate, but we can make a pretty good estimate at it. So it's 38 weeks or earlier, then it's preterm. Now, you should recognize immediately that it depends. If we're talking about complications of it being preterm, it depends on how close you are to that 38 mark, right? Because who can recall what full pregnancy is, full term? Right, so 38 is not too shabby. If you can make it to 38, certainly baby's viable. There may be a couple things that it's still developing, but there's a big difference between 37 and a half weeks and 28 weeks, right? And so keep that in mind as we go through. So we'll say okay. So less than or at 38 weeks is preterm. And so the biggest issue that you have, or the thing that will indicate what health problems you might expect, is birth weight. And so average birth weight, as you know, is around 3,400 grams, so 7.5 pounds. As I've told the other classes, I get that in the Dakotas and Iowa and Minnesota that 7.5 pounds seems like a small baby. But that's average across the country. Most places, when I first came here and people were like, and my wife, we were having our first, and they were like, my baby was 10.5 pounds. I was like, what are you? What creature are you? But 7.5 pounds is average. Now, 5.5 pounds, if you're at 5.5 pounds, which is 2,500 grams, you'd be considered low birth weight as a fetus or an infant neonate. Does that make sense? And so, everybody have that? Wants it?
What's the normal size
Yeah, 7.5, 7.5. And so 3,400 grams. And 2,500 grams for 5.5 pounds. Now, it may seem silly trying to remember grams when you already know pounds. And maybe depends on what career path you plan on taking. If you're going into research or medicine, then it's a good idea to start getting used to using more precise measurement. If you're not, then whatever. I'm not going to ask you to convert. So if you see it on a test, at least for this, I'll ask you in pounds. Fair enough? So even though, or it's true that only 7% of all births are low birth weight, but the problem is that 7% disproportionately makes up for the majority of all deaths, infant mortality. Now, we said that we were going to talk about small for gestational age. And so, if a neonate is at 90% of the average or less, it's considered small for gestational age. So if the average is 7.5 pounds, you can work out what 90% or less would be. The thing is, though, you have to take context into consideration. So I've told the other classes about my sister-in-law and her husband, who, for all intents and purposes, are hobbits. They're very, very small people. And, I mean, it's comic. I mean, it's strange. But at any rate, so they're lovely people. But their children, their 3 children, were all born very small. Which makes sense, because it's not just they're small. They both have family histories of being smaller. So really thin, really short, and that's kind of how it is. You wouldn't expect them to birth a Minnesota butterball. Time for Thanksgiving. No, that's gross. Cannibalism is wrong. So you have to take context into consideration. It may be that it's not on the average that a birth weight doesn't seem to fit within the norm, but for those parents it is normal, and that's important too. So within that realm of low birth weight, even the small for gestational age, one of the biggest things that one would be worried about is respiratory distress syndrome. And it's very simply because lungs aren't fully developed. Remember, we said that you have a maturational trajectory in utero. And so even if you're born early, you still have to complete that maturational trajectory. So if your lungs haven't fully developed in utero, they still have to continue that developmental process, out in the world. Because they're underdeveloped, they're more susceptible to infections, lung infections, all of these other things. And as we know, those can be painful and devastating even if you're a full-blown adult, right? You get a lung infection and it kind of sucks. And it can put you out for a while. Imagine being a 5.5-pound baby. Other concerns are that these infants are easily chilled. All neonates are easily chilled because they don't have a lot of fat. Fat gives us insulation, right? Which is why I walk around in the winter in t-shirts. And it helps us regulate, to some degree, regulate our temperature. Now, neonates can't do that. Low birth weight infants especially can't do that. And so That's why the standard of care is that if you have a preterm baby, they go in the incubator. So they get supplemental oxygen, which helps with the underdevelopment of their lungs, right? We'll see in a video where this person that they're interviewing, they never give her credentials, but this person they're interviewing talks about a device that actually draws CO2 out of the infant to help with that kind of that process. And of course, the incubator keeps the infant warm, right? Now, before we go into the very low birth weight, we should say that 60% of all preterm infants are just fine. They develop normally. There may be a slight delay in that first year, but they usually, by school age, they're up to snuff, and there's no big deal. And 38% have intellectual disabilities of some kind, and it could be mild, could be very mild, but there may be some delay there. Now, very low birth weight infants are a completely different story, and so these are infants that are around 2.5 pounds. And so it's about 1,250 grams, which is 2.25 pounds. But just imagine around 2.5 pounds. So there's not much difference between a quarter and a half in this case. And so these infants are born anything. So any baby that's born less than 30 weeks would be considered this, but of course birth weight itself counts. So it's the combination of the two. They're born before 30 weeks, and this case is having. Now your textbook will tell you that a baby's viable at 22 weeks. You'll hear 23 weeks here. It's not true. A baby with modern medicine is viable, usually at 22, 23 weeks, with an incubator and all these things. But that's not the same thing as saying the baby is viable, meaning that you could birth them, in your house in Georgia and everything would be okay. It certainly would not. And even with an incubator and all of modern medicine, a baby at that around, at very low birth weight has a 50% chance of survival only. And so it's quite a serious thing. And of course, you'll notice your textbook talks about cost, that it's very expensive to get a very low birth weight infant. It's very expensive for any preterm infant to have them in the NICU. But I feel like that's more of a stressor after the fact. I've never, and I'm not saying it doesn't happen, but I've never heard of a situation where someone has given birth to a premature infant and someone came in and said, this is going to cost a lot, do you really want to do it? Like, that just doesn't happen. But there could be implications, because we'll see that there is some correlation between delivering preterm and low birth weight and socioeconomic status and all of these other things. And so if that's true, then you might imagine that maybe insurance isn't as good as it could be. And so these individuals may be facing significant bills, which could then kind of spiral. You're not paying for college if, 28 years later you're still trying to pay that initial birth cost. And that's hyperbole. Know that it takes that long. Okay, so let us watch our video. And you guys hit the lights. It's not a good video, but it should be informative. And there's no worksheet.
Unfortunately, not all expecting mothers are able to carry their unborn child to term. Often, in these situations, the infant is unable to live on its own since the baby's body is not yet fully developed. In these cases, a premature baby spends its time in the neonatal intensive care unit where the baby receives the care it needs.
Okay, premature baby is any baby that is 23 weeks gestation and above. 23 weeks is considered the stage of viability, so that means that the baby has enough lung capacity, even though the lungs are extremely premature, but the organs and everything, the organ systems are prepared to be integrated with life.
Premature babies are often extremely small compared to full-term babies. The outfit this woman is showing illustrates the size difference between a full-term and premature infant. The yellow outfit is the typical size of a full-term infant, whereas the white outfit is showing the size of a premature baby.
For the most part, the smallest baby that I have ever seen is 13 ounces. That's about the size of a Coke can. And that was a 23-week baby. It was small for gestational age and it had uterine growth development. So just, knowing that a baby like that, who's now almost a year old, doing great.
There are many technologies in the neonatal intensive care unit that helps the infant compensate for its underdevelopment. Two of the best technologies that the unit provides are the high-frequency ventilator and the oscillator that help the viability of the infant.
Now, since there's so many advances in technology, the higher frequency ventilator is a big one. The oscillator, those are different type of oxygenation systems. The oscillator actually pulls carbon dioxide out of the baby. That's a big thing that you look for in premature babies, if how much oxygen they're getting, but also how much carbon dioxide they're blowing off. So with the oscillator, with the high frequency ventilator, if you ever notice the baby breathe, they're breathing a lot faster than us, so they're exchanging a lot more oxygen at a faster rate. So with high frequency ventilator, you can really kind of mimic that as well. So that has definitely advanced developmental aspects of premature babies. Developmental care as well. That just means how the nurses and how the people who are taking care of the babies handle them. Just knowing different things that can happen with babies who are premature, such as blind and deafness. Like I said before, if a premature baby gets too much oxygen, then the likelihood of their retina detaching increases. Their ears aren't fully developed at 23 weeks. So that's another issue that they have, is just being deaf. And
There are many causes to premature birth of an infant. Some of the causes can be avoided by the mother, while others the mother cannot help.
And this record is caused by an incompetent cervix. A cervix that dilates too early in the pregnancy is one of the biggest ones. And if you are a candidate for that, you should not have sex when you're pregnant. That semen has progesterone in it, so that kind of intensifies labor, makes it go faster. If you are something like that, if you have pregnancy-induced hypertension, then that means you probably have more fluid on board within your whole body, and you're gaining more weight. It's a baby at risk because you're not getting as much blood flow. Definitely drugs and alcohol, if you are ingesting those when you're pregnant. That gives the baby, especially cocaine. Cocaine does cause abruption in babies. That's when the uterus completely just erupts and extreme, just bloody everywhere. The baby stool is bloody the whole time. For about 3 days afterwards, you can get blood out of the baby's stomach, everything. The causes just generally temperature.
The neonatal intensive care unit has everything that the nurses and doctors will need to help the viability of the premature baby. There are machines that give the infant air, monitor their heart and respiration rates, and tools needed to perform tests on the infant. The technologies help the infant overcome their underdevelopments and become a full-term healthy infant.
Yay. From our friends in Cedar Rapids. Yeah.
Did you hear about the artificial womb that they made? I don't know.
Artificial
I read.
womb?
Yeah, so I read this article a few months back that they had I don't know who they is, but some scientists have created an artificial womb with artificial amniotic fluid, and they've only tested it on lambs so far, but the lambs can survive a month in this artificial fluid after being born premature.
Oh.
So they're trying to obviously alter it to like make it work on humans, but.
That's really interesting. If you remember or can get back to the link to wherever that is, send it to me and I'll put it on Moodle for everybody to check out. It's very interesting. I know they're doing, so there's an active area of translational research along the same lines of looking at ways to make surrogate wombs viable, especially for people who have trouble maintaining a birth or conceiving a baby. Okay. I was sorry, I was debating because we'll watch one more just at the end. But okay, so we've seen our friends in Cedar Rapids talk about it. If she wasn't pregnant, I would have thought she was drunk. I think they just did really bad editing. But interestingly, and I don't know this is the case, I'm making a big assumption here. It may be she was suffering from pregnancy brain, or what my wife calls pregnancy brain as well. So there's, I should put it up, there's some legit research looking at that and what hormones contribute to it. But during my wife's pregnancy, she had a lot of trouble finding words. And it's really difficult if you see cancer patients for a living, right? And so her fallback word was, "That's amazing." She couldn't find it, she'd be like, "Amazing." Like, it's completely out of context. And so I kept waiting for her to say, "Preterm infants are amazing." But they aren't. They are. You're little bundles of a miracle. Okay, so this is our next video we'll talk about. But before we move on, we should talk about stillbirth a little bit. Now, you probably noticed since there's a delay that I posted a thing on Moodle. If you haven't, it's up there. Basically, someone in the first section asked, when we were talking about stillbirth, asked about, so I mentioned that if you have a stillbirth, that usually the dead fetus will remain until its full term, until the full term time occurs. And so the question was, is that safe, and why would that be true? And I said, I really don't know. It's not my area, but that's what my experience has been. And so I looked it up because I definitely did not know the answer. And what it seems is that, so a couple things are going on in areas where you're required to have where they're not extracting the fetus. They seem to be in areas where there's legislation that prevents 20-week abortions, so anything over 20 weeks. And apparently, it's considered, even though this fetus is dead, it's considered that if you do any intervention after 20 weeks, regardless of the status, it's considered an abortion under the law. So that's why in some states it's illegal to do that, which is absurd to me, but that's probably where I got that idea. What it seems also is that if an infant dies, so if you have a stillborn infant, that within 2 to 3 weeks, the mother will spontaneously start labor. So you wouldn't necessarily have to induce. However, some mothers in states where those laws don't exist will choose to be induced or have the fetus extracted simply because of the emotional trauma of carrying around their child that has just passed away. Pay attention when you're thinking about these issues to the terminology, because we've already seen a number of times through this course where these divisions are somewhat arbitrary. So for example, if it happens before 20 weeks, we wouldn't call it stillborn, we would call it a miscarriage, right? And then if you have, once delivery happens, it's only infant mortality if it happens within the first year. To a parent, it doesn't, 1 year, 1.5 years, whatever, it's still just, it's pretty much the same thing. But for statistics, it's important to have a sense of these events in their isolation because there's increased risk, say, after a certain period of time, right? So if we say that we're close to some amount of viability, then we ought to have a sense of what the risk of, as the fetus progresses, what the risk of or not miscarriage, but stillbirth is. And also within that first year, once an infant makes it past the first year, their risk for death or risk for succumbing to SIDS or something like that drops markedly. However, like I said, there's to the parent, there's very little difference. And of course, with stillbirth, you can just assume depression. There aren't really cases where, and you would have to, couldn't imagine what a cold person would not be depressed if mother and father, if that were the case. So that makes sense. And there is some chance for post-traumatic stress disorder. How that manifests will depend on the individual and a lot of other factors. And of course, you would expect the parents to grieve in the same way that they would for an infant that was delivered live, and simply as a time for sensitivity, which you would think is just makes sense, right? You'd be sensitive, but if you have X number of patients and you're on an L&D ward or you're in that situation, then it may not be that you're not being sensitive, it may be that you just have a lot of people to take care of. And so there isn't a lot of time to sit down and strike up a campfire with somebody about their feelings. And so those are the times where if you're in that situation, you remind yourself, okay, time to slow it down and make sure these people know that we're there for them. Okay. So we're not going to go through the reflexes to a great deal. You already have that sheet, the handout sheet. It should be sufficient. If there's confusion, we'll certainly kind of walk through it, but I think it all makes sense and you've done the reading, so that's fine. Classical conditioning and operant condition, we've already talked, we're going to talk about that a lot this semester. We've talked about it already a little bit, so we're not going to worry about it today. But we will watch this video on habituation. Now, the caveat is that habituation isn't limited to work with infants. Habituation can occur with babies, animals, adults, whomever. You can habituate to pain, you can habituate to any noxious stimulus, really. You can habituate to certain stimuli. And if you'll see this with the research with adults, you want to, especially if you want to measure something like change inhibition, that you want to see how much they've habituated to this stimulus they've been trained on. And the way you would find that out, the same way she'll talk about in infants, is if you show something that's novel, some slight change that's obvious enough that they can catch it, if you want to see how long they attend to that, because we naturally attend to new things longer, and by longer we're talking milliseconds, right? That's still sufficient. And so if you ever are asked to take a psych test where they're doing reaction times, that's what they're doing, because if you're a few milliseconds slower, it meant that you were doing a lot of cognitive processing. And we can, of course, we'll talk about all of that when we get to those chapters, but it's fun stuff. Okay. Yay.
Here at BC, we're looking at exactly what it is that infants, children, and adults know about number, time, and basic quantities such as surface area and other what are known as perceptual quantities. Traditionally, it's been assumed that children, let alone infants, were incapable of perceiving number, of keeping track of number. There have been a number of studies coming out from my lab and as well as other labs revealing that infants are actually very capable of keeping track of number, and even when different perceptual attributes of the display change. So, for example, the surface area or the configuration of items on a display change from trial to trial, infants will still take away from the display the number of items on the display. But what these findings are telling us are that infants are actually much more tuned into number, and they're paying attention to number at a much earlier age than we once thought. So it's hypothesized that, in fact, the ease with which infants can discriminate number early on seems to be linked to later mathematics achievement in the classroom. So the experiments that I'm using to measure how infants keep track of number
are based on the basic habituation technique. And it's a behavioral measure in which we're measuring how long infants look at the display. We bring her in there, and you're with her at all times. Put her in a high chair and have her watch some things on a screen, and we're interested in what she looks at. So we'll be videotaping her. The infants are habituated, so they see a display of a given number of items over and over again. The display may change in configuration or in surface area, for example, but there will always be the same number of items in the display. So they'll see 5 items over and over and over again. Each time it'll be 5 dogs, 5 cats, 5 dots, 5 anything. Then in test, they see either a greater number of items, so they'll see 10 items, or they may see 3 items in test. And if the infant looks longer to the display with a different number of items, this suggests that they actually noticed the change and that they're keeping track of the number of items in the display. Hopefully, all this work will lead to an enhanced understanding of early representations of quantity in the hopes of targeting early mathematics achievement and finding ways to make children better counters and better problem solvers. We know that keeping track of basic quantity is very important, not just for learning early mathematics, but it's also important for language acquisition, decision making, foraging, some really basic cognitive skills that take place. And so we think that infants are using these counting and timing abilities to learn about the world and make predictions about, well, mommy's coming back in 30 seconds. Now, he doesn't know 30 seconds, but they are able to predict that their mother will return to the room fairly soon because they know that she always steps out for this amount of time.
Okay, you can do the remainder with the lights off. So we're fast approaching our exit, but something else to consider, and I don't know what this researcher, what her opinion on these things are, but something else to consider is we see that in almost all social animals, that there's this second mathematics sense. So it's not a sense with named numbers, but it's a general sense of how many you have and how many I have. And one of the reasons why this is very important is for reciprocity. So in all social animals, pick a wolf, pick a whatever, and you'll see there's a lot of grooming, or in higher order primates, condolence, all these other things. It's very important to be able to keep track of who scratched my back so that you can go and scratch their back later, right? And we'll talk about social ramifications later. Now, that's not to say that a young infant is doing that. It's to say that you have to start developing those skills earlier on so that you can do it. And we'll talk later about building off of this cheating and fairness. Now, I'm not talking about cheating in the relationship sense. I'm talking about being able to perceive if you're being cheated. So you're at, how do you evaluate the people at the Walmart oil change place? Did they really do it, kind of thing? I mean, you could think of a lot of other things. But we'll talk about all of that later. Now, again, don't forget that we'll be in the computer lab on Monday. Don't forget to sign the attendance sheet if you haven't done so already. And listen, as you're reading the next bit, we're going to spend more time after we come back from workday talking about the physiological development. When you're reading through that information, if you don't understand the neuronal development initially, just try and get a sense for what's happening in general, and we'll go through it. We'll explain that out, okay? All right, I will see you all in October. Yes?
Me too. My dorm room. I know that. How do you know that? So I know our dorm room is decked out. So
It would be
our door is fully decorated.
somewhat acceptable to
Like fake What? Katie and I.
I don't think I had it. I don't think it necessarily.
Yeah.
Plus,
You want to use
So it would be a good idea to sign up.
well, you get over the entire presentation.
First floor group leaders meet together, and then the second floor group, like in a chronological order.
Okay.
get together. And you can choose to all get together if you want. But, you'll want to set up a meeting.
Which I was looking at this earlier too. So.
Yeah, the group meeting, because we haven't.
Right.
Right. And so, thank you. The reason why we've divided it 4 and 4 is because it's harder to kind of schedules for people together.
So this is just for one class period for right? It's not like all of the members of every single.
Right, yeah, just one class. And so